So Dr. Nimitha will be presenting Gonioscopy, unlocking the angle and revealing glaucoma secrets. She is a consultant from Comtrust Eye Hospital, Calicut.
So I'll be talking on gonioscopy. So primarily gonioscopy is basically done to differentiate open angle from angle closure disease. And this is the gonioscopic picture of open angle. Whereas when there is an iridotrabecular contact, the angles are closed and none of the structures get visible. So the concept of gonioscopy, usually we cannot visualize the angle structures due to total internal reflection, and gonioscope lens eliminates this total internal reflection. And why is gonioscopy important? Because to identify primary angle closure disease from open angle, as primary angle closure disease has more risk for blindness. So what are the things required for gonioscopy? One is the dark room, the small slit, and the Goldman 2 mirror lens. So first we put paraffin in the patient's eyes, and we make sure the patient's chin is resting on the chin rest, and the forehead should be touching the slit lamp forehead band. And with the help of the gonio lens, you ask the patient to look up and make the illumination less, and with your forefinger or a swab stick, you place the gonio lens. So this is how the gonio lens is being placed. Other than that, we can use the viscous agent also. So there are two types of gonioscopy, that is the direct as well as the indirect gonioscopy. In the indirect, there is the non-indentation and the indentation. The indentation is where the surface area is larger than the cornea, and we use the viscous gel, whereas the non-indentation, whereas in the indentation, the surface area is smaller than the cornea, and the patient's tear film is used. There is other different types of gonio lens available, that is the Goldman single mirror, Posner, and Sussman is also available. In direct gonioscopy, we make the patient lie supine, and we place the gonio lens such that the angle structures are visible. The various lenses available are the Swan-Jacob, Copies, and the Barkins. For Copies, we require a handheld slit lamp. The structures visible through gonio lens, that is this darkish band which is visible, that is the ciliary body band. Then there is the scleral spur. Then there is the trabecular meshwork, that is the posterior trabecular meshwork. Then there is the anterior, and then anterior trabecular meshwork, and then there is the Schwal base line. So it is important to make a corneal wedge. The corneal wedge, basically you hold the slit lamp at a 30, the two arms of the slit lamp should be made at a 30-degree angle, and then you identify you make a thin slit, and there will be these two other thin slit, and one is from the corneal endothelium and the other one is from the corneal epithelium, and where the line meets, that is the Schwal base line. So if the structures are visible beyond the Schwal base line, that is indicative of open angle, and if the structure is not visible, that is indicative of closed angle. And here you can see a double hump pattern, that is indicative of a plateau iris. So in this gonioscope, you can see that you feel that these angles are actually closed. But when you make a thin slit and you identify the Schwal base line, actually the angles are open. Then this is a gonioscope picture where you can see a uniform pigmentation of the trabecular meshwork, and you can see a Schwal base line and the concave iris configuration, which is all indicative of pigment dispersion syndrome. Other than that, you can see in this gonioscope picture there is a small white fluffy dandruff-like material and patchy pigmentation of the trabecular meshwork and the Schwalbe and the Sampolicis line seen, which is seen in pseudo-exfoliation syndrome. So here the angle structures, here in this gonioscope picture, you can see the iris is coming in contact with the trabecular meshwork. The trabecular meshwork is coming in contact with the Schwalbe's line, and as a result, none of the structures are seen. And this is basically a peripheral anterior synechiae which is seen. And this peripheral anterior synechiae is usually broad, irregular, and it reaches only up to the trabecular meshwork, and none of the structures are visible. So in this, you can see that the angle is actually closed, and you can see a volcano-like configuration, that is the Fuji sign which is seen. This is the lenticular mechanism of angle closure. In this video, basically, none of the angle structures are visible, but as soon as I press over the cornea, you can see few of the structures visible. So if none of the angles, if few structures are visible, it is indicative of appositional, whereas none of the angle structures are visible, it is indicative of synechial angle closure. So the new vessels, they are usually fine arborizing, and it usually crosses the scleral spur. So here you can see that there are fine new vessels seen in gonioscope. This is a gonioscopic picture where you can see prominent iris processes and Schwalbe's lines seen. That is indicative of accent field anomaly. This is another gonioscopic picture where you can see the ciliary processes and also an iris stump indicative of aniridia. This is another gonioscopic picture where you can see a widened ciliary body band seen in angle recession. This is a gonioscopic picture of a foreign body seen in the angle. It's a glass piece seen. This is another gonioscopic picture where you can see the ostium and a large iris, large peripheral iridotomy done in post trabeculectomy. This is a gonioscopic picture of silicone oil seen in the angle. This is another gonioscopic picture where you can see stent, eye stent, and also tube in the angle. So for sterilization, we usually clean the gonioscopic lens with running water or 70% isopropyl alcohol. So to summarize, first when you do a gonioscopy, you identify the Schwalbe's line, you enumerate the structures. If you can see the structures beyond the Schwalbe's line, it is indicative of open angle. Other than that, it is angle closure. If you indent, if the angle opens up, it is appositional closure. If it is not, then it is synechial or plateau iris. And this is a diagrammatic representation. We usually use the Schaffer's grading, where grade 0 is closed and grade 4 is open. And contraindicated gonioscopy is usually contraindicated in painfully inflamed eye, acute angle closure glaucoma with edematous cornea, or suspected open globe injury.